Alrighty, welcome. Research class, correct? Very good. So I've got a bunch of very experienced practitioners here who need to kind of keep their merit badge. So welcome to your ACLS research course. This actually, I think, is a fabulous opportunity to do a lot of things. Part of it is we are constantly, as if I have any choice in this, the American Heart Association is constantly changing and upgrading ways that we are taking care of patients who have strokes, who are having heart attacks, and we're kind of expanding it to all sorts of different areas. You know, there's conversations about drownings and things along that line. And in doing so, you get to refresh what's going on in the new literature, which is kind of nice. So rather than sitting around and being a junkie and reading journals all the time and trying to figure out, okay, do I do a hypothermic protocol now? Do I not do it? How many temperatures or how many degrees do I need to lower them to? You get to come through every 2 years for these updates, and hopefully we kind of get you back up to speed. So most of the basics that you guys have learned and have been practicing for the last few years still stays the same. So if there's one thing that you should walk away with an ACLS course is an idea of how to do good quality CPR. I've been teaching and been part of teaching ACLS for, God, probably almost 20 years now. And that is the one thing that has been consistent all the way through. Drugs have come and gone. Those of you who have been in the trenches forever remember beryllium way back when, right? Now we don't even talk about it. My guess will be in the next 8 to 10 years, the emphasis or the use of things like epinephrine are going to completely fall out of the wayside because those have never been shown to be effective. We do it because a lot of times we don't have much else to use. But the thing that keeps coming around over and over again is early electricity for shockable rhythms and good quality CPR. Okay, so, and we're going to be talking today about both strokes advancements and cardiac care advancements. And then you're going to break, you're going to have a few more lectures, and then probably the most important thing that you're going to do today is play around with the equipment again. And that, I think, is probably the big learning point for those of you who haven't done this a lot. So I look out and I see a lot of my ER nurses, God bless you. I'm sure there's some ICU nurses and everything else. You guys play with this equipment probably far more than you want to, right? Bagging patients all the time, watching intubations, things along that line. Some folks get to work in areas where that's not as common of a procedure. Perfectly fine. That's great. It means hopefully things are going well where you are. This is an opportunity for you to play with the stuff, to figure out how do I put a mask on a patient? Which end of an ampule do I squeeze into the IV? You will be amazed how many times there are certain areas in the hospital that I know when I descend into the basement for a code that it is guaranteed that there'll be 35 people there and nobody's doing anything. Okay, so, and a lot of that is just because it doesn't happen very often. So the more you practice, and practice as you're going to actually play, the better off you're going to do. Because there's nothing more nerve-wracking than getting called to a code blue or having someone drop right in front of you, and it's you and the custodial service. And you're like, oh crap, I'm the senior person here. Ready, go. And then figure out how to take care of that. So use each other as a resource. You guys all have had fabulous experiences. You all have a tremendous amount of knowledge in this room. So as you're going through these scenarios, you might be going through one of the Brady dysrhythmia scenarios on your cards. If you have a good story about somebody who had hyperkalemia, about somebody who had a 3rd degree heart block, and what you guys did, and why you gave your 0.5 milligram of atropine, and what, you know, maybe you did transcutaneous pacing. You know, maybe you got to see one of our residents or one of us float a transvenous pacer. Share that with the group. It's that type of knowledge that once you personalize it, you can really get a lot more out of it, okay? If you've gone through the respiratory arrests, if you've gone through the feudal codes, I'm sure everybody in here has been part of the code of the 92-year-old metastatic patient who has a GI bleed and a stroke, and I mean the laundry list, and they're on dialysis, and every time you do chest compressions, the eye blood vessels start popping and hemorrhaging all over the place, and you're like, oh my God. You know, that feeling. Or those of you who might have done codes on kids and how you dealt with that and the discussion that you had afterwards, share those with each other. These are the real learning experiences that you're going to have from this stuff, okay? So again, you're all given those cards. On the front side are slow rhythms, on the back side are fast rhythms. The things that you really need to know is what requires electricity and what doesn't, right? So any of your wide complex tachycardias, anybody that's unstable in an AFib, whether it's wide or narrow complex, shock them, okay? And don't be afraid of doing it, right? Pretty much if they're that unstable, they're close to death, Giving them a little bit of Cook County electricity is not going to make them any more dead. Okay? Your people that are walkie-talkie, not unstable, you've got time, right? So you might look at these monomorphic VTACs, and it's at 140 or 50, and they're sitting there on their phone texting, our positive texting sign, right? Okay, you got time to play around with that. So you might step back and go, great, I can do my IVO2s monitors. What's the first thing I might want to do? Maybe I want to give some amiodarone. Maybe I want to give some magnesium. You've got time with those things. So differentiate your unstable, which is I got to go in and do something now. If it's shockable, I shock them. If it's a PEA arrest, well, I got to figure out my reversible causes. Maybe it's oxygen, maybe it's hyperkalemia. You can go through your H's and T's and all that stuff. If it's asystole, now if it's asystole and the patient's talking to you, I had a resident say this to me once, oh my God, they're in asystole, and the patient's like, what are you talking about? I'm like, I don't think so. You actually need to hook the leads up. So then they were much better off of that. Okay, so, you know, you guys have a lot of experience. So look at your patient, you'll have an idea what you're dealing with. Patient's talking to you, you got some time. Patient's not talking to you, okay, it's time to boogie woogie. All right, we're gonna talk about two things today, and I'll stop in between the two because Mark's taping me, and anyway, that's what it is. So we're going to start with stroke and new advances in stroke. Now, I am not going to insult your intelligence and explain to you what strokes are. You guys are all very familiar with strokes. You know strokes take things away, okay? A lot of times, patients do not understand this, and it is difficult to talk them off the ledge. They'll tell you, my elbow hurts. I think it's a stroke. And you go, no. If your elbow was completely numb and your arm all the way down, that could be a stroke. Pain is not a sign of stroke. Unless you had a stroke and you're hemiparetic on the right side and you fell down and you broke your arm and now it hurts, okay, that's a different story. But just by itself, it doesn't do that. It takes things away. So the classic things we talk about, grandma's sitting there on Mother's Day breakfast, everyone always takes grandma out for brunch, and she's sitting there watching her whole family, and all of a sudden her face droops to the right side. Okay, that's a classic stroke-like symptom. Some of the smaller ones, people go and they want to go pick up their car keys and all of a sudden they can't grab with their left hand anymore. Those are stroke-like symptoms. One of my favorite ones is the guy that came in 2 days after his symptoms started. He had the left-sided facial weakness and actually had right-sided facial weakness, a little bit of right arm weakness, and didn't bother him too much until he came in. I said, well, why'd you wait 2 days? And he said, well, you know, I could use my left arm okay to open my beer. But every time I went to drink my beer, it kept pouring out of the side of my face. And I was like, all right, that's a true guy, motivated by his beer consumption. Okay, so it takes away functions, whether it is speech, whether it is the ability to form normal speech. Has anyone in here seen a Wernicke's aphasia? We talk about Broca's all the time, if you remember that term. Those are the people that are kind of slurring their words, they can't articulate. Has anyone seen a Wernicke's stroke? Those are really interesting. They say normal formed words, but they make no sense. And they get really frustrated because they know what they want to say, but that part of their brain is stroked out. So they might go, dog run, hit space, and they want to get a hold of a bottle, okay? Different type of stroke there. The inability to formulate proper sentences, okay? So that's what you're looking for, functions that are gone. When you see that, you need to ask yourself one of a couple questions, okay? You look at it and you go, oh my God, this could be a stroke. But there are two really common mimickers that we talk about all the time that we check for, or at least ask about, that can mimic those strokes. So what's the most common one? Hypoglycemia, exactly. Hypoglycemia is the most common kind of mimicker of stroke. And you guys have probably all seen a hypoglycemic patient. What happens? They start to slouch to one side, they kind of drool a little bit, you know. I tell a story about a time that I was young and exceptionally stupid, mostly because I confronted a charge nurse who had years and years and years of experience. And they brought back this little old lady, and she was slunched to the side and doing this stuff, and she's like, oh, it has a stroke, and she was kind of telling me all about this stroke. And so I said, well, you know, let's get a blood glucose. And like, oh, there's obviously a stroke, and you know, the family saw it, and I said, well, let's get a blood glucose. The blood glucose comes back at 14. So we give the glucose, and the patient gets much better, and I said, wow, I found a new cure for stroke. Man, I got assigned the worst patients from there on out. She was not happy with me. So good learning experiences, yes. Hypoglycemia looks just like a stroke, and B, do not piss off your charge nurse because then your life is miserable after that. So watch for hypoglycemia. In the ER and on the floor, when you call a code stroke, we like to have a sugar within how much time? Like 0 time. I mean, ideally within a minute. So someone calls code stroke, someone should be on their finger pricking it and figure out this is not hypoglycemia. If you're euglycemic or hyperglycemic, you know sugar is not involved in that one. Okay. What's the other condition that commonly mimics a stroke? TIA. Okay, well, TIA is like a stroke that is resolved by definition. What else? Seizures. Very good. Now, if you have the luxury of watching somebody do the floppy chicken in front of you, and then when they're done, they're kind of drooling on their side, it's like, well, I know what that is. That's postictal, right? But that rarely happens. It's usually, and what we hear in the ER all the time is, I walked in on them, we heard this thunderous noise in their bedroom, and we walked in, and there they were sitting in bed, and they couldn't use the right side of their body. Oh my God, we think they had a stroke. And then you start getting some history, and oh, they have seizures. Oh, they haven't been taking their Dilantin. Oh, you know. So watch for that stuff, right? Hypoglycemia and seizures. Now, it used to be when I gave this lecture 3 or 4 years ago that a seizure history was a contraindication for using TPA, clot busters. That is no longer the case, okay? If you have a seizure history, and you come in with stroke-like symptoms, and you're in our window, so for most people 3 hours, or for some other people 4.5, we'll talk about that in a little bit, you can still give them TPA, okay? Now, if you know that this is a postictal period, I would not recommend giving TPA to somebody unless you really just don't like them, and you want to give them a risk of some bleeding and things like that, okay? So ask for your history of seizures, and is this a seizure? One particular one, called Todd's paralysis, is where you're left with paresis on part of your body from a seizure, right? Seizure is just a short circuiting of the brain, okay? And hypoglycemia. Those are the 2 things that we want to look for, okay? So, what are we going to do with these things? Those of you guys who have been around the ER, those of you guys who are up on the floor that do code strokes, you know the hallmark. Quick, get in there, get your sugars, grab your baseline labs, do a quick neuro exam, figure out where the deficits are, and then off to CT scan, right? What are we looking for in the CT scan? Bleed. That's it, right? Everyone said, oh, do you see a stroke? That's not what I'm looking for. I am looking for a hemorrhage versus non-hemorrhage. Okay, about 15% of all strokes are hemorrhagic strokes. Those people you don't want to give blood thinners to. That's a bad mojo, right? You're already bleeding in your head, make you bleed more. That's not a good way to go, okay? Those people go to wonderful physicians like Dr. Sikorsky. Those people, we try to lower and control their blood pressure. We try to keep them from swelling in their brain. Depending on where the bleed is, they may or may not go to the operating room. Okay, so your hemorrhagic strokes, those 15%, total different group that we handle differently. The vast majority of the ones that we see, the TIAs that we have, the still continuing strokes, 85% of those are thromboembolic strokes, okay? Of those, 15% usually come from AFib. The other ones come from carotids, or you just had bad luck. You had some sort of clot that has gone up into your brain, okay? So we get them out to a CT scanner. We want to get there within 25 minutes. We want to get it read within 60 minutes. And we're asking ourselves, do you have a bleed or not? That's it. Now, there's all sorts of subtle things that we can see on CT scans based on how old the stroke is and everything else. We can start seeing some gray-white interface. Doesn't matter. That's not what we're asking. We're asking bleed versus no bleed, okay? If you don't have a bleed, then we proceed to the next step. And this is the critical part. How long have you had these symptoms? And you guys have probably, maybe not, heard of the NINS study. That was the first study that kind of kicked off this great, big, huge trial of whether or not we use clot busters, TPA, on stroke patients. So originally when they did this study, way back when, 10, 15 years ago, they said, you know what, we're going to take all these strokes that show up in the emergency department, and we're going to give them these clot busters, and we're going to see what happens. Okay? And what happened when they did this? They were knocking off people right and left. Lots of people were hemorrhagic conversions, they were dying. It looked terrible. Okay? But true to science, we stopped and said, okay, this really sucks. There's got to be some subgroup somewhere that's getting some kind of benefit. And so when they went back through and crunched all the numbers of the thousands of people that they enrolled, they said, lo and behold, those people who had symptoms for about 3 hours or less, they actually did a little bit better. They didn't bleed as much, and they got a little bit more benefit. After 3 hours, what we saw was bleeding rates started to go through the roof, and benefit started to decline. So the original FDA approval was for 3 hours of onset. And this is why it's so critical. Everyone wants to know, when did this stroke start? And the definition is the last time this patient was seen normal. So if grandma goes to bed at 6 o'clock at night after she saw hee-haw and ate some food, and then wakes up at 2 o'clock in the morning to go to the bathroom and the right side of her body is not working, grandma's last normal time was 6 p.m. when she went to bed, okay? We'll get phone calls all the time. Oh, I talked to so-and-so on the phone at 7 a.m. in the morning. Great. Then I called them up at 11 and started speaking to them, and they were sounding like gibberish and slurring their words. Last time they were normal, unless the patient can tell you, was 7 a.m. in the morning. Okay? That's our go time. For those of you that are working on the floors, it'll be the last time you saw that patient normal. And we hear this a lot. You know, I checked in, did vitals at 8 o'clock. When I went back in, because I hit the call light at 9 o'clock, they were now slunched down. They couldn't use their right arm. 8 o'clock was your go time. You now have 2 hours in your window to get your TPA. Okay? So, unfortunately, as was mentioned earlier with TIAs, a lot of folks have TIAs where the symptoms come and go. This is a very common thing that I hear. I was at home and, I couldn't use my hand for about 30 minutes, but then it came back. Oh, that's kind of cool. And then 2 days later, it took about 45 minutes for it to go. And now I'm in the ER because it's been 3 hours and I still haven't had function back. Okay? This is why so few people, only 2% of the people that probably could get TPA, do get TPA. Because there's such a delay from the time these symptoms, especially when they have a history of these symptoms coming and going. And that's what the TIAs are. And unfortunately, TIAs will run anywhere from a 6 to an 8% chance of having a severe stroke in the next 30 days. So it's a pretty big warning sign if somebody has it. But we as people, and especially, I'm going to be sexist, as guys, are great deniers. I mean, I was just jogging yesterday and I had chest pain about 3 miles into my run. I'm like, yeah, I'll just run a little harder and see how this goes. And it went away. So it could have been a heart attack, right? Okay. I mean, and I know better. God, that's what I do every single day. Kim's like, what are you thinking? I've been doing this since I was 16, though, running. So, I just run through the pain. So if I drop in dead sometime, you'll know, well, I guess he was wrong. But people deny this stuff all the time, and that's what we typically see with these TIAs and stroke-like stuff. If they've had them on and off before, they'll ignore them, and then by the time we get to them, it's a little bit too late. Okay, so 3 hours, big time frame in there. There is a small group of people that we are now extending it to 4.5 hours. All right, you might have heard this. They're called unicorns. They don't exist in Berrien County. They can't have diabetes. They can't have hypertension. So it's like, those people don't exist here anymore. But there is a small select group of people that we can extend it out to 4.5 hours. There is always a push by, I think, the drug companies and the neurologists to try to extend this window farther and farther and farther. Most ER folks are not quite as thrilled with this, mostly because if they bleed, they usually bleed in front of us. And we're the ones that have to take care of the mess and explain to the family, I'm sorry, we pushed this medication and now they're herniating because they're bleeding all through their brain. Okay. I don't ask you guys to know very many numbers, but the one number I do want you to know is 6 to 8%. Okay? And the reason is that is the bleeding complication for giving TPA to stroke patients. Why do I want you to know this? It's on the test, okay? But more practically, it's what families are going to want to talk to you about. This never fails. So I go in and I'm consulting with a family, their loved one is there, they've had a stroke, maybe the symptoms have been there for an hour, they're a TPA candidate. And I give them the benefits and the risks. And I will go through and say, we have this medicine, it can potentially break up the clots, it has been shown to improve outcome at 30 and 60 days, not instantaneously. I don't expect to give this medicine and now they're playing Chopin on the piano. But at 30 and 60 days, they do better than their cohorts. But there's a 6 to 8% chance that this will convert into bleeding in their brain, which could be fatal. And I explain this to the family, explain this to the patient, and they all kind of dutifully look at me, nod their heads. And then I leave, and we have curtains in the ER. And as I leave, and the curtain closes, the family turns to the nurse and goes, what would you do? They never ask the doc, what would you do? They always ask the nurse, what would you do? Okay? Because I think they recognize doctors are not humans and nurses are humans, and that's just the way it runs. So be prepared to be asked this question. So my ER nurses out there, have you guys been asked that by family members? Yeah, to a T. And you need to have an honest answer of what you would do. I know when I am asked, my typical answer is, if I'm with it enough to say no, don't give it to me. Okay? Because that means my neurodeficit's probably not so bad that I don't mind living around with a little slurred speech or an inability to use my right hand or something like that. If I'm so gorked that I can't say anything, then give it to me because I either want a chance to get better or I want off this ride. Okay, that's me. Everybody has a different value system, but have something ready because you don't want to be caught in that position where all eyes in the room are on you and you go, check please, I'd like to get out of here. So just be prepared for that. And those are the numbers that are important to know on that one. 6 to 8%, be ready. I promise you families will ask you. And there's not a problem in saying what you would personally do. You can't tell them what to do, but you can say what you would do for yourself. And they really appreciate that because families really look up to their nurses. That's seriously, right? You know, and you turn away and they're doing this stuff. But some of them will stick with this story. You know, I've had many patients that will come in and they'll slur their speech, and you just want to say, don't do this. I know it's not a stroke, and but you still have to go through that whole entire thing. So a lot of people do end up getting TPA that turn out after you do the MRI and everything else don't have strokes. Those people's bleeding risk factor is a lot lower. So there's a great study that looked at TPA that we gave for people who had pulmonary emboli, right? Clot busters for things in the lungs. They had about a 1% chance of bleeding in their brain. So not a 0, but certainly better than the 6 to 8. So instead of, you know, knocking off 1 out of every 17 people, which is about what it is for people who are actually having real strokes, you get to 1 out of 99 or 1 out of 50, depending on which studies you read, for just if we all lined up and said, yeah, light me up with a little bit of TPA, okay, thin the herd by 1 out of 50. Okay, so it's not a benign medication, but you will. Now, you're absolutely correct. Do you have other forms of bleeding problems? You bet. If you've got a history of GI bleeding, you know, we ask, are you actively bleeding anywhere? But yeah, it can increase your risk of GI bleeding. Those of you who have taken care of people who had TPA and you start IVs, those are nasty, right? You poke them and they just like ooze all over the place forever and ever and ever. One of my least favorite things in the entire world when I was working up in the ICU is somebody who's on TPA and then I got a phone call. Oh, the IV blew. Can you put in a central line? Like, are you kidding me? You know, this hematoma bulges out of the side of their neck, and you know that's, you have to be careful with that. But yes, they can bleed everywhere. I've had patients that have had horrible nosebleeds that we can't stop once we give TPA to them. It's a tough one, you know, and it's a tough one to reverse on that. Okay, so that's your 3-hour window. Those are your numbers. You guys have a pretty good idea what to look at, and we've got an extended group of 4 to up to 4.5 hours. Now there's.
So who are the ones that are 4.5 hours?
The 3 to 4.5 hours, those are people that have very low risk factors. So those people, they can't be diabetic, they have to be below the age of 80, they have to have relatively controlled blood pressure, they really can't have very many comorbidities. Those are your rare people that are like 52 that have AFib for whatever reason and just blew a clot. Okay. There is one other treatment that some of you may have been exposed to or heard about that we are using more and more, and that is basically the endovascular TPA, where they go in and they break up the clots just like the cardiologists do. So now, I probably shouldn't say this because I'm being taped, but I don't care. That's fine. Neurologists have always been cardiology wannabes, right? They are always like 8 to 10 years behind the cardiologists. Cardiologists came out, you know, many, many years ago and said, oh my gosh, you have this big clogged up artery in your heart, and let's just use some liquid Drano on it, streptokinase, we're gonna blow that stuff out and you'll get better. And they did it, and then the cardiologists got the new cars and the Porsches and, you know, the adoring fans and everything else, and the neurologists were sitting on the sideline going, that's not fair. Those guys are cool, I wanna be cool like them. So then they developed TPA for the strokes a few years later. Okay, well, then the cardiologist said, well, that was so yesterday. We're going to go in now and we're going to do stents, and we're going to do, you know, interventional cardiology, and we're going to blow up those clots, and we're going to do all those wonderful things that we do in a cath lab. And then they got the new cars again, and the neurologists were left driving around the Priuses and all that stuff and thought, you know, that's not cool. We want to be cool like the cardiologists. We want to go in and we want to grab out these clots as well. And they tried to do that. And for quite a few years, the studies showed that this did not work well at all. Bleeding complications were too high. We weren't getting the good resolution until the Mr. Clean study that came out about 2 years ago out of the Netherlands. And what they did is they took a very select group of people. These were individuals who had fairly severe strokes, were relatively healthy people, and had large proximal clots. Meaning, the most common areas that you get your clots are your middle cerebrals and your anterior cerebrals. These were clots that were near those vessels where they started, so they were large, knocking off large portions of the brain. They were able to go in and do interluminal TPA and blow those things up, okay? We can still do those, and you can do those up to 8 hours. So some of our patients who have fairly debilitating, devastating strokes that we've already given TPA to, so we've already given the general in your IV, your 90 milligrams, and the whole kit that we do with that, we can send those folks over to Bronson, where they will then go in with a guide wire and actually try to specifically find it. Now, it usually requires either a diffusion MRI or an IVCT to allow us to see exactly where that clot is, because it's got to be a proximal clot. If it's one of these small clots out in a small blood vessel, bleeding risk is way too high. So some of our patients, and I think last year, I think we sent about 8 to 10 people over to Bronson for this. 2 of them were my patients. Their patients had pretty obvious onset, debilitating strokes that took out a large vessel, right? If you just lose function of your hand, that means you have a pretty small clot kind of in the outside of the cortex. If you lose the entire half of your body, that means it's a pretty large clot and it's pretty close to where one of those vessels comes off, okay? So those folks go over there. They had 2 of the 8 that were successful. The other 6 weren't. Okay? 4 of those ended up bleeding. And you could argue these people had horribly debilitating strokes, so giving them some chance was better than probably the little to no chance that they had, because usually when you have strokes that are that significant, you end up having significant swelling in the brain, you have to worry about herniation, all sorts of other stuff. They went to craniotomies, they do not have good outcomes. So at least they gave them some opportunities, and 2 of them were very, very good successes and had near full recovery. So you might find with some of these patients that we will be shipping them out rather than keeping them here, but they do get the TPA. Okay. The other thing that I didn't mention as we do the stroke stuff is probably the cheapest and one of the most effective things, and that's aspirin, right? So if we don't get if we get our CT back and there's no hemorrhage and they pass their swallowing study, we give them aspirin. What happens if they fail their swallowing study? They still get aspirin. How do we give them aspirin? Up the backside, that's right. All we need is give me a mucosal surface and some aspirin and I'll find a way to get it into you, okay? And I say this affectionately like I'm putting the aspirin up their backside. My wonderful nurses are doing that as I'm walking out the room and, you know, eating my jalapeno chips or something like that. Okay. So those are kind of the updates on strokes. Big thing to remember, know your 3-hour window. There are some people that we can extend it out to 4.5 hours. You don't necessarily need to know who those folks are, but they're relatively healthy younger folks that we can do that to. We can do the endovascular retrieval on people who have very significant strokes. Know that you've got to get your glucose early on. You guys already know your signs and symptoms of stroke. Again, we want to do aspirin for those folks. What really ultimately at the end of the day makes all the difference in stroke centers? Stroke centers have been shown to have much better outcomes for patients who have strokes than non-stroke centers. Is it because we have these unbelievably dashing and good-looking ER physicians? No, we have nothing to do with it. How about our great ER nurses? As much as I love you, no. How about our ICU docs? We make the biggest benefits on our stroke patients day 2 through 7, 8, and 10. It's in the rehab area. It's preventing your stroke patients from getting catheter-associated urinary tract infections. It is preventing your patients who have dysphagia from getting aspiration pneumonias and dying of pneumonias. It is keeping your patients who have hemiparesis from getting decubitus ulcers by meticulous care to wounds and things along that line. That's where stroke centers make the biggest difference. It's the OT and PT that you get after you've had your stroke that gets you functioning and back to life. So as much as I would love to take credit for something like that, it has nothing to do with what the ER folks are doing or even the early acute care people. I mean, you guys are saving lives and keeping them from dying and, you know, okay, that's important. But really the big benefits that we make in stroke is downstream. So those of you guys, if you're working in any of those units, thank you very much. That's the big difference in stroke care. All right. Any questions?
So the aspirin, you can give before you do the TPA?
Yep. Yep, because TPA affects the intrinsic clotting system. What does aspirin affect? Platelets. And we'll get into that even more when we start talking about the cardiac stuff. Because there's really 2 arms that we're going to be affecting in anybody that you want to stop clotting. One is taking out those pesky little platelets, and that's either going to be done by aspirin or Plavix or one of the other type, medications in that one. And then you need to take care of the intrinsic clotting factors, okay? And for the heart, we don't do this in stroke, but for the heart, we're going to use heparin or Lovenox for that aspect, or we're going to use TNK as a clot buster, okay? And we want to take care of both of those. We'll get into that in a bit. All right, any last questions on strokes? Going once, twice. All right, Mark, did you want to switch over? Or are you good?